So next we have Dr. Fairooz. She is an eminent oculoplastic surgeon practicing in Bangalore and several other places, and also a scientific committee member. So I thank Dr. Fairooz for being a part of our course. She'll be talking about OSSN and how we can keep the surface safe.
Good morning, everyone, and happy to have you all here in this session. Ritvija, thank you so much for making this IC a very diverse one, including an tumor in a reconstruction IC. So I will be speaking to you regarding ocular surface squamous neoplasia. How do we keep the ocular surface safe? Interesting. So we all know that ocular surface squamous neoplasia involves the ocular surface, which is the limbus. So it is due to the transitional zone theory, where the basal epithelial cells of the limbus undergoes transformation, and there is dysplastic changes, which is extending to the cornea and the conjunctiva. So this is the basic etiopathology of OSSN. Now, UVB radiation is considered to be the most etiological agent, where it can cause damage, DNA damage, and there is the pyrimidine derivatives of these cells undergo proliferation and then dysplasia, carcinoma in situ, and then it's a spectrum. Human papilloma virus is also yet another etiological agent, where even UVB radiation can cause changes in the HPV virus, activate it, and then further cause the neoplastic changes. So as you can see here, this is an ASOCT where you can see the limbus is involved, where the tumor is extending into the cornea and into the conjunctiva. So ocular surface squamous neoplasia is a spectrum. The spectrum involves dysplasia in one end, which can be mild, moderate, and severe. Then it goes to carcinoma in situ, and further to invasive squamous cell carcinoma. So we have a pre-invasive OSSN and an invasive OSSN. Now let's see how we can safeguard the surface in the management of ocular surface squamous neoplasia. I'm going to ask this question and put this question to the audience over here. So this was a patient who came for a second opinion for this lesion in the cornea. He was advised surgical excision of the lesion, keratectomy probably. How many in the audience would prefer surgical excision of this lesion? Sir, okay. Anyone else? What else do we have as an option here?
Topical treatment.
Topical treatment, yeah. So I decided that I'm going to go for a topical treatment because I want to preserve the surface, all right? Although it's arising from the limbus, most of the extension is into the cornea. So I want to preserve the cornea here. And we have excellent topical immunotherapy and chemotherapy with it, where you can actually preserve the limbal cells, the epithelial cells of the cornea, and get rid of this. So this is the ASOCT, where this is very, very typical of OSSN, where you have the snouty appearance and affecting the epithelium of the cornea. I just did 3 cycles of topical interferon in this case, and he has an amazing surface. The surface is preserved and the lesion disappeared. So in this one slide, because of the paucity of the time, I'm going to show you how the topical chemotherapy in ocular surface squamous neoplasia work from the same review of literature that we had published many years back. So the options that we have is mitomycin C, 5-FU, interferon alpha 2B. Now, what I consider when I select a drug for my patient is definitely the surface. The drug with least surface toxicity is something that I would prefer. Let me take you to the adverse effects. So with mitomycin C, conjunctival hyperemia, blepharospasm, a lot of surface toxicity is reported with mitomycin C. When you come to 5-FU, well, the surface toxicity slightly reduces. And interferon, the surface toxicity is almost nil. You don't have conjunctival hyperemia. The patient is very comfortable. The only thing that they might land up is when you inject it in a larger dose, they might have a flu-like syndrome. So for the same reason, the advantages of topical chemotherapy is no surgical compromise of the surface, less invasive modality. It causes chemoreduction, and it also can target subclinical and residual tumor cells. Now, if you ask me what is my favorite topical chemotherapeutic agent or immunotherapy, I wouldn't shy in telling my most favorite is interferon because of the less surface toxicity. And my second favorite would be 5-FU. Well, MMC in my practice, I actually don't use it anymore because of the surface toxicity. Now the cost factor. All right, yeah. So I'm going to compare United States and India regarding the cost factor of each. So 5-FU is very, very cheap. So if you see, it's like $1, all right? It's 50 rupees, less than 50 rupees a vial for 5-FU. And interferon, it comes to around 1,200 rupees in India, but well, it's slightly expensive in United States of America. $17 in Indian. Sir? Slightly more expensive, right, yeah. But it is affordable in our patients, like, yeah, when you compare to the surgery. Sir? Slightly more in United States. I agree, right, yeah. So this is a slide where I just want to highlight how topical chemotherapy, works in ocular surface squamous neoplasia. Now, there is definitive indications. I know that we want to take care of the surface, but as an ocular oncologist, for me, getting rid of that tumor and this tumor not progressing into an invasive, neoplasia or a cancer is very, very important. So these are the definitive indications. When it's corneal OSSN, well, you want to preserve the corneal epithelial cells, non-invasive superficial lesions, large tumors to chemoreduce, diffuse placoid OSSN, adjuvant post-surgery in positive margins. So most of the time, when a patient comes post-surgical, for my opinion, some patients are on topical chemotherapeutic drugs despite excision biopsy and a negative margin. I think that is not what we practice. If pathologically, after an excision biopsy, you can prove that the margins are negative, there is no need to put the patient on further topical chemotherapeutic agents. You're done with the treatment, but keep the patient on regular follow-up. So these are the lesions that exactly what and where I would use topical therapy for the good surface. So this was a young patient, a 15-year-old, immunocompromised HIV, where she came with this lesion with lots of keratin over here. She has been treated on steroids, but the typical keratin over the surface says that it's a diffuse OSSN in an immunocompromised patient. The only thing that I did was topical interferon alpha-2b therapy, and this is 6 months post-treatment, and she is disease-free for the past 7 years. Now, we can have multiple lesions, okay? So these are 2 foci of OSSN in the ocular surface here. Excising this would be a large excision, right? Including both these. So again, what I did was injection, intralesional interferon alpha-2b and topical interferon alpha-2b. So in my practice, I most of the time add intralesional because the resolution is more quicker. Just with topical interferon, this might take like 6 months or 8 months. But if I inject, trust me, 3 months, you can find complete resolution of the tumor. Now, again, lesions like this where, you have to make sure that it's not invasive. Clinically, how would I make sure is with a cotton bud tip, I would try to move the lesion. If it is fixed, then that means there is some amount of invasion. But note that at the limbus, most of the lesions are fixed. I'm talking about the conjunctival side, all right? And of course, ASOCT will help you with that. Large lesion like this, and these are all intralesional interferon, topical interferon, 3 months of treatment with combo. This patient was referred to me as query conjunctival melanoma because of the pigmentation. So in pigmented population, like Asian population, African population, you have a variety of pigmentary form of OSSN. So this is actually OSSN. You can find this papillary fronds over it, all right? And in fact, when I looked into the other eye, all right, he had a small corneal OSSN also in that corner. So what I did was I injected the left eye, which is the diffuse one over here, and topical chemotherapy for the right eye. And he was socioeconomically quite backward. He didn't have a refrigerator. He was a farmer at home. So I couldn't give him topical interferon alpha 2B because it requires cold chain, maintenance of cold chain in a refrigerator. So what I did was put him on topical 5-FU for that reason and intralesional interferon. So it's a combination of two drugs over here taking care of this patient. As I told you, a combo of intralesional and topical chemotherapy can reduce the resolution. As you can see here, it's just 5 weeks for the resolution of the tumor. Now, a diffuse lesion over here, how would I go about that? Is I would take map biopsies and prove that where are the regions where the tumor is positive. She has tarsal involvement, caruncular involvement, superior tarsal involvement, and the conjunctiva was involved. All these were positive. So how do I do an intralesional injection? This is kind of a diffuse situation. In focal one, close to the lesion, away from the lesion, I would inject into the lesion, but this is very diffuse. So what we do is inject with a 30 gauge needle, causing a diffuse ballooning of the conjunctiva. I would also go intratarsal and a cryotherapy because she had an eyelid margin involvement. And well, voila. This is how she is with this diffuse involvement. So the surface has been preserved here, avoiding extensive surgery in here. Now, there are certain situations, well, of course, invasive squamous cell carcinoma. This is an immunocompromised patient. This is immunocompetent patient, where surgery is the gold standard. You know, if it's invasive, well, no chemotherapy, topical, no immunotherapy. Now, even while doing surgery, we have certain steps that we take care so that, again, the surface is very well preserved. So taking a margin, a 4 millimeter margin all along the lesion in order to get a free margin in histopathology to reduce the recurrence is very, very important. With the free margin, the recurrence is less than 3%, whereas with the positive margin, the recurrence is as high as 35%. Now, this patient had an invasive squamous cell carcinoma, so there is a sclerectomy which is being done, and this is keratoepithelectomy which is being done. In cornea, we go 2 millimeters around the lesion, so the entire lesion is separated, and from the limbus, where the origin or the pinnacle of the OSSN is, we kind of resect it. Well, a meticulous dissection is very important, and then cryotherapy is something that we do, which is so very, very important, double freeze thaw cryotherapy. And taking care of the surface is with amniotic membrane graft, and this is applied with a tissue glue. All right, so this is just a brief overview, margin clearance, complete excision, taking care of the surface with amniotic membrane graft, and cryotherapy. So this is a paper which is one of my favorite. It came in 2014. In fact, we all started using interferon in 2014, where there is not much of a difference in recurrence in surgical excision versus interferon. Now, after excision biopsy, this is an AMG well kept, well in place, we can have histopathology showing that there is base positivity, where there is, the tumor cells are in the base. So the treatment doesn't end there, right? So we give a plaque brachytherapy for the surface. So for the margin, if it's positive, it's topical chemotherapy. If base is positive, then we give a plaque brachytherapy. Now, giving plaque brachytherapy to the ocular surface, the dosage that we use is around 4,000 to 5,000 centigrade. It's not harmful for the surface, so this is how the surface looks after plaque brachytherapy. So concluding, topical chemotherapy is non-invasive. It preserves the ocular surface, especially in corneal OSSN and non-invasive OSSN. It's excellent in outcome, and primary wide surgical excision is the gold standard in invasive squamous cell carcinoma. Well, amniotic membrane graft has to be used for surface reconstruction for a safer surface. And plaque brachytherapy in invasive tumors, well, it is definitely safe for ocular surface, as you saw in that case with the amount of dosage that we give for radiation. So thank you, Ritwija. So we share a good bond, a sisterhood bond, and you have been doing excellent job as an upcoming oculoplastic surgeon and oncology. So it's a pleasure being here today. Well, I also would like to remind you, we have the International Society of Ocular Oncology, which is coming up in December in Goa. It's an international conference. So I request and invite all of you for this conference. Thank you so much for your patient listening. Thanks.
Thank you, Dr. Fairooz. And indeed, it was a mesmerizing presentation because it covered each and every aspect with such a good variety of cases. So it was a treat to watch. And I think all of you have got a lot of learning from this, especially on when to use topical therapy, when to go in and do surgery, how to image, and how to decide on treatment. So she's the authority. So thank you for that.
Thank you, Ritwija. It's a pleasure.